Hello, my dear doctors. Welcome back to Conquer Pathology with Dr. P. Today, we are diving into the war room of the human body. We are talking about immunopathology. This unit is the bridge between basic science and the medicine you will practice in the wards. Whether it's a patient sneezing from pollen, a young woman with a butterfly rash, or the global challenge of HIV, it all starts here. I have broken this lecture down to cover NMC competencies PA 9.1 to PA 9.7 in detail. We will connect the dots with medicine, pharmacology, and microbiology, so you don't just memorize this, you understand it. Grab your notebooks, we have a lot of ground to cover. First, PA 9.1. What is immunity? It's simply protection from infectious disease. Think of your body as a fortress. It has two lines of defense: innate immunity and adaptive immunity. Innate immunity is natural or native. This is your always-on defense. It's the police force patrolling the streets. It has no memory and no specificity. It treats every intruder the same. Its components are physical barriers like skin and mucosa, the fortress walls, cells like neutrophils, the rapid response foot soldiers, the macrophages, the heavy tanks, and natural killer cells, soluble proteins, the complement system, and acute phase reactants. If a thief enters a bank, the security guard, that is your innate immunity, tackles him immediately. He doesn't ask for ID, he just stops the threat. The next line of defense is adaptive immunity, which is acquired and specific. This is the SWAT team. It takes time to mobilize, from days to weeks, but it is highly specific and has memory. Humoral immunity, B cells. It is mediated by antibodies IgG, A, M, E, D. It targets extracellular microbes like bacteria in blood. Cellular immunity, T cells. It is mediated by T lymphocytes and targets intracellular microbes like viruses, TB. CD4 plus helper T cells, the generals. They don't kill, they shout orders. That is, they release cytokines to tell everyone else what to do. T helper 1 cells activates macrophages, causing cell-mediated immunity. Th2 activates B cells and activate humoral or allergy. Th17 recruits neutrophils and cause inflammation. CD8 plus cytotoxic T cells. They are the assassins. They directly kill infected cells. Now let's look at our next mission, which is identification. We are securing the perimeter of the human body. We are covering the immunology of the HLA system and the transplant rejection protocols. If you want to understand how the body defends itself, you have to understand the security system first. Let's move on. First stop is the security checkpoint. The core concept here is self versus non-self. Your immune system relies on the major histocompatibility complex, MHC, to verify identity. In humans, we call this HLA, or human leukocyte antigen. This is encoded on chromosome 6. Think of HLA as the biological ID card. If you don't have the card, you don't get in. We have two major players guarding the gates, MHC Class 1 and MHC Class 2. Let's break down their patrol routes. MHC Class 1 is found on all nucleated cells plus platelets. It presents to CD8 plus cytotoxic T cells. The antigen source is endogenous. These are proteins made inside the cell like viral proteins. MHC Class 2. It has restricted access. It is located only on antigen-presenting cells like dendritic cells, macrophages, and B cells. It presents to CD4 plus helper T cells. The antigen source is exogenous, things eaten from outside like bacteria. This is how you memorize it instantly. Dr. P's cheat sheet, the rule of 8. Do the math with me. MHC1 multiplied by CD8 equals 8. Look at the loci. HLA-A, HLA-B, HLA-C all have one letter. So MHC1. MHC2 times CD4 equals 8. Look at the loci. HLA-DP, HLA-DQ, HLA-DR all have two letters. Never forget it. Now the conflict. We are talking about transplant rejection. Here's the scenario. We have a donor kidney and T cell units. The problem here is the donor MHC does not equal the recipient MHC. When the ID doesn't match, the rejection sequence is initiated. The attack begins. There are three types you need to know for your exams. Type 1 hyperacute rejection. The time frame is minutes to hours. This is immediate failure. The mechanism here is, it is caused by pre-formed antibodies. It is a type 2 hypersensitivity reaction. The patient must have prior exposure like a previous pregnancy or blood transfusion. Look for thrombotic occlusion of capillaries and fibrinoid necrosis. The organ dies before the surgeon even closes up. Type 2, acute rejection. The time frame here is weeks, usually days to weeks. Mechanism is primarily T-cell mediated, though antibodies can play a role. Clinically, the patient presents with fever and rising creatinine. You will see mononuclear cell infiltration, lymphocytes attacking the tubules. Is it treatable? Yes, it is. The treatment is immunosuppression with steroids or cyclosporin. Type 3, chronic rejection. The time frame is months to years. Look at that shrunken, scarred kidney. The mechanism is the cytokines induce a fibrosis. It's a slow burn. The hallmark here is arteriosclerosis, vessel thickening that looks like onion skinning plus interstitial fibrosis. It is irreversible, and once this starts, we can't stop it. How do we stop this war? We'll look at strategic intervention, that is prevention. I'm handing you 2 strategy cards. Cross-matching. The goal here is to prevent hyperacute rejection. We check for preformed antibodies right now. HLA typing. The goal is to minimize acute and chronic rejection, and we match the ID cards, that is the haplotypes. Final debrief. Here is the rejection matrix. Hyperacute, minutes to hours, preformed antibodies, thrombosis, and not reversible. Acute, weeks, T cells, lymphocytic infiltration, yes, reversible. Chronic, months to years, cytokines and fibrosis, arteriosclerosis, and not reversible. Now we are opening the file on the hypersensitivity protocol. This is your competency number PA 9.2. We are doing a high-yield board review on investigating injurious immune reactions, so let's get to it. Listen up. This is the mission brief. We are looking at an inside job. You need to understand that hypersensitivity isn't an infection. It is an injurious immune reaction. Essentially, our own defense force has gone rogue. Look at the intel box. Hypersensitivity is defined as an exaggerated or inappropriate immune response that results in host tissue damage. Our mission requires precise intel. Here's the breakdown of rogue operations based on the Gell and Coombs classification system. We use the classification code ACID, ACID, to memorize this. A is for anaphylactic, the immediate reaction. C is for cytotoxic, the antibody-mediated reaction. I is for immune complex, antigen-antibody complexes. And D is for delayed, that is cell-mediated. Let's look at type 1A, the explosive saboteur. This is the anaphylactic or immediate reaction. Here's the villain profile. We are dealing with immunoglobulin E. The operative here is the mast cell, our soldier. Weapon is IgE antibody, which acts like the gun. The IgE antibodies are attached to Fc receptors on the mast cell, and the primary targets are vasculature and smooth muscle. Threat level here is critical, and this happens in minutes. This is the critical chain reaction. Timing is everything. Sensitization. Upon first exposure, the body creates IgE. This IgE attaches to mast cells. We call this loading the gun. Re-exposure. The antigen returns and cross-links the IgE on the mast cell surface. This is the trigger. And then degranulation, the explosion. The mast cells release histamine and other mediators. Here's the damage report. Morphologically, you see vasodilation causing redness, edema causing swelling, and smooth muscle spasm causing bronchoconstriction. Clinical examples are, locally we have hay fever and asthma, and systemically we have anaphylaxis like from a bee sting or penicillin. But we have an antidote, adrenaline. This is the physiological antagonist. Why? Because it does the exact opposite of histamine. It causes vasoconstriction to raise BP and bronchodilation to open the airway. Moving to type 2C, the targeted assassin. This is cytotoxic or antibody mediated. Our agent here is IgG or IgM antibodies. Target are antigens that are fixed on a specific cell surface. It works through precision strikes. No collateral damage is intended here. The antibodies identify the target cell and call for its immediate destruction. How do they execute the target? We have 2 methods of elimination. Tactic A. opsonization, which is the marker. Think of it as an eat me sign. The antibody coats the cell and the macrophage eats it via phagocytosis. Examples here are autoimmune hemolytic anemia and Rh incompatibility. Tactic B, inflammation or the fire. The antibody activates the complement system. This calls in neutrophils, which cause tissue damage. Examples are Goodpasture syndrome and rheumatic heart disease. There is a type 2 special tactic, cellular dysfunction. Call this the hacker. Here the antibody binds to a receptor and turns it on or off without destroying the cell. For example, Graves' disease. The antibody activates the TSH receptor, leading to hyperthyroidism. And the next example is myasthenia gravis. The antibody blocks the acetylcholine receptor, leading to muscle weakness. Next is type 3I, the clog. This is immune complex mediated. Here the problem isn't the agent itself, it's the debris. Antigen plus antibody makes an immune complex. These complexes form in the body and get stuck in the body's filters. Where do these systemic failures occur? These filters get clogged. The deposition sites or the filters are kidneys, especially the glomeruli, joints, and small vessels. For example, SLE, Lupus. It involves nuclear antigens. Post-streptococcal glomerulonephritis involving streptococcal antigen, and serum sickness from foreign proteins like anti-snake venom. Morphologically, you see fibrinoid necrosis or vasculitis. Finally, type 4D, the sleeper cell. This is delayed or cell-mediated. Key player here are T cells. There are no antibodies detected here. It takes 48 to 72 hours to mobilize, and this one plays the long game, deploying agents only after a delay. Subtype 1 is CD4 plus mediated, the organizer. The CD4 plus Th1 cell is the commander. It uses cytokines as signals. Th1 cells activate macrophages, leading to inflammation and granuloma formation. The commander organizes a blockade. This granuloma wall traps the pathogen but also causes inflammation. For example, tuberculosis, leprosy, sarcoidosis. For diagnostics, remember the Mentus test. You must wait 48 to 72 hours to read it. Subtype 2 is CD8 plus mediated, the executioner. It causes direct T cell cytotoxicity, no mercy. The CD8 plus T cells use perforin and granzyme to cause cell lysis. The executioner directly takes out target cells. Examples are type 1 diabetes, where the immune system kills beta cells, and contact dermatitis, like a poison IV reaction. Here's your tactical overview, the ACID matrix. This is your rapid fire guide, lock and load. Type 1, IgE, mast cells, immediate asthma and anaphylaxis. Type 2, IgG or IgM, cell surface, Graves or hemolysis. Type 3, antigen-antibody complexes, deposition and filters, SLE or serum sickness. Type 4, T cells, no antibodies, delayed, tuberculosis or contact dermatitis. Now we'll face the ultimate autoimmune antagonist. We'll be talking about systemic lupus erythematosus, SLE. This is the prototype of autoimmunity. If you understand lupus, you understand the entire concept of the body turning against itself. First, the origin story. Why does this happen? It comes down to a failure of tolerance. Look at the formula on the screen. The trigger. You take genetics, specifically HLA genes, and add the environment like infection or UV light. This causes a chain reaction. Central tolerance fails. Then peripheral tolerance fails. As I always say, when both defense systems fail, we get autoimmunity. How does the anemia attack? Step 1. The defect. The body fails to clear apoptotic bodies. It's a waste disposal problem. This leaves nuclear DNA exposed. The body sees this DNA and creates anti-nuclear antibodies. This leads to two types of warfare. Type 3 hypersensitivity, the clog. Immune complexes deposit in the kidney and skin. And type 2 hypersensitivity, direct fire. Antibodies attack RBCs and platelets. Now let's do some reconnaissance. How do you spot the enemy? We use the classic mnemonic SOAP BRAIN MD. S for serositis, O for oral ulcers, painless, A for arthritis, non-erosive, P is for photosensitivity, B is for blood disorders, R is renal involvement, which is critical, A is ANA positive, I is immunologic, N is neurologic, for example seizures, M is malar rash, the butterfly rash, and D is discoid rash. Forget the old rules. We are using the update patch, the 2019 EULAR or ACR criteria. Think of this like a video game. Level 1, you must pass the entry level, the gatekeeper. Level 2, you must collect points. And level 3, you need a score of 10 or more to win the diagnosis. So let's begin with level 1, the gatekeeper. The test is ANA, anti-nuclear antibody. Here's the rule. If the ANA is negative, stop. It's not SLE, game over. If the ANA titer is more than 1:80 on HEP2 cells, go proceed to level 2, which is collecting points. We assess 7 clinical and 3 immunological domains. The golden rule here is you can only count the highest weighted item in a domain, don't double count. Rule of attribution, don't count a fever if they have malaria. It must be due to lupus. Let's look at the point values. Constitutional or fever is 2 points. Hematologic, autoimmune hemolysis is big 4 points. Neuro, seizures give you 5 points. Mucocutaneous, acute cutaneous lupus or malar rash is a heavyweight worth 6 points. Moving to the body, joints, synovitis is 6 points. But here's the boss fight, the renal domain. This is the most common cause of death. Look at my cheat code here. If a patient is ANA positive and has class 3 or 4 nephritis on biopsy, that is 10 points. Automatic win. You don't need any other symptoms. Diagnosis confirmed. Speaking of the kidney, you need to know the morphology for the lab exam. Class 1 or 2 is mild, class 3 is focal, and class 4 diffuse. These are the severe ones. Microscopically, look for the wire loop lesion. This is the immune complex deposition thickening the capillary wall. Now for the lab report. We check for antiphospholipid antibodies and low complement C3 and C4. But the heavyweights 6 points are the specific antibodies anti-dsDNA or anti-Smith. Memorize this cheat sheet. This is high yield. ANA is the best screening test. It is sensitive but not specific. Anti-Smith is highly specific. Anti-dsDNA is also highly specific and correlates with disease activity like kidney damage. Anti-histone is a specific for drug-induced lupus. Remember the drugs procainamide, hydralazine, and isoniazid. ANA positive plus a score of 10 or more equals SLE. So we have conquered lupus, the prototype. Now we need to talk about the family. Now we are profiling the autoimmune cousins of SLE. We are looking at 2 distinct pathologies, Sjogren syndrome and systemic sclerosis. From dry eyes to hardened skin, let's break down the mechanics of PA 9.7. We call them cousins because they share the same autoimmune roots as lupus, but their personality is different. We have 2 main paths today. Path A is Sjogren syndrome. I call this the destroyer of moisture. It targets the glands. Path B is systemic sclerosis, also known as Scleroderma. This is the fibrosis factory. It targets connective tissue. Let's start with cousin number 1, Sjogren. What is the mechanism? Look at the slide. Lymphocytic infiltration. It's an invasion. CD4 plus T cells attack the exocrine glands, specifically the lacrimal or the tear glands and salivary or the spit glands. The equation here is immune destruction causes glandular dysfunction. If you kill the gland, you can't make the fluid. This leads to the hallmark clinical representation, the Sicca complex. The 2 major complaints in these patients are keratoconjunctivitis sicca. That's medical speak for dry eyes. Patients describe it as a gritty sandpaper feeling or like there is dirt in their eyes. Xerostomia, dry mouth. They have trouble swallowing dry food like crackers and have fissures in the tongue. How do we tag this suspect? We look at the serology. We are looking for 2 specific antibodies against ribonucleoproteins, anti-SSA, also called Rho, and anti-SSB, also called La. Remember, SS stands for Sjogren syndrome. If you see Rho and La, think Sjogren. But here is a warning. This isn't just about dry eyes. Sjogren syndrome has a dark side. These patients have a 40-fold increased risk of developing B-cell lymphoma. If your patient with long-standing Sjogren suddenly develops a unilateral enlargement of the parotid gland, biopsy it immediately. That is cancer until proven otherwise. Now let's switch to cousin number 2, systemic sclerosis. Sclero means hard, derma means skin. This is a fibrosis factory. It runs on a deadly triad, autoimmunity, vascular damage, and massive fibrosis or collagen deposition. We classify this agent into two types based on how much skin is involved. Diffuse scleroderma is everywhere. Widespread skin involvement and early visceral organ damage is seen, for example in lungs, kidneys, everywhere. Limited scleroderma is restricted, usually just the fingers and face. This one is slower and more benign. For the limited form, remember the acronym CREST. C is for calcinosis, calcium deposits. R is Raynaud's phenomenon, blue fingers in cold. E is esophageal dysmotility, you can't swallow. S is sclerodactyly, skin of fingers gets tight. And T is telangiectasia, red spots on skin. How do we distinguish them in the lab? For diffuse, look for anti-SCL70 against DNA topoisomerase 1. SCL is for scleroderma. And for limited or CREST, look for anti-centromere. The memory hook here is centromere is for CREST. Look at these clinical signatures on the slide. This is what fibrosis looks like. Mask-like face. The skin is so tight, they lose their facial wrinkles and expressions. The mouth opening becomes small. That is microstomia. Claw-like hands. We call this sclerodactyly. The fingers contract and curl because the skin is too tight to move. Time for the showdown. Let's compare them side by side. The primary target. Sjogren hits glands, scleroderma hits connective tissue. Key antibodies in Sjogren is Rho and La, and scleroderma is SCL70 or centromere. Major feature of Sjogren is dryness, while that of scleroderma is hardening. Major risk of Sjogren is lymphoma, whereas that of scleroderma is renal crisis and pulmonary fibrosis. So here's your final review. Snapshot this for exam. Sjogren's is dry eyes, dry mouth, anti-rolla, and watch for lymphoma, and diffuse scleroderma, widespread fibrosis plus anti-SCL70. Limited scleroderma, CREST syndrome plus anti-centromere. Now let's open a major case file, HIV and AIDS. This isn't just a virus, it's a master of disguise. We are going to track it from the moment it enters the body to the final diagnosis. We are covering competency PA 9.6, viral structure, pathogenesis, and the NACO testing strategies. Put your gloves on, let's examine the suspect. First we need a description. Here's the enemy profile. We are looking for a retrovirus with a very specific toolkit. Look at the surface proteins. GP120. This is the key. It picks the lock on your immune cells. GP41. This is the crowbar. It pries the cell open for entry. P24. This is the core. We call this the capsid antigen. Remember P24. This is the target we look for in early screening with 4th generation ELISA. It's the fingerprint left at the scene. How does the crime go down? We call this the hijack. It happens in 3 steps. In step 1, the GP120 binds to the CD4 plus T cell. The virus handcuffs the general. Step 2, it needs an accomplice. It binds to a co-receptor CCR5 or CXCR4. Step 3, GP41, the crowbar, pierces the membrane causing fusion. Once inside, it uses reverse transcriptase to rewrite the code. The cell is now a factory for the enemy. Every crime has a timeline. Watch the CD4 count, the blue line, crash while the viral load, the red line, spikes. Acute phase. There is massive viral spike, the patient feels like they have the flu. Clinical latency. The suspect goes underground. The virus is replicating quietly in the lymph nodes. AIDS phase. The defense collapses, CD4 count drops below 200, and now the opportunistic infections move in. Now let's see AIDS defining opportunistic infections. Respiratory. Pneumocystis girovecii pneumonia. It gives ground glass appearance on X-ray. Tuberculosis, often extrapulmonary. In CNS, we see toxoplasmosis, the ring-enhancing lesions, and cryptococcal meningitis. In GI, we see esophageal candidiasis, cryptosporidium, causing chronic diarrhea. Malignancies. Kaposi sarcoma. It is caused by HHV8. It is a vascular tumor and is seen as red or purple patches on skin. Invasive cervical cancer. It is HPV driven. Non-Hodgkin's lymphoma, EBV driven. How do we catch them? We follow the NACO guidelines. We have 3 different strategies depending on why we are testing. You don't just run a test, you run a strategy. Strategy 1 is for blood safety. Strategy 2 is for surveillance. Strategy 3 is for diagnosis of a symptomatic patient. First, understand the three kits A1, A2 and A3. SA1 or A1 must have high sensitivity. We don't want to miss anyone. Usually a 4th generation ELISA detects P24 antigen and antibodies. SA2 or A2 and SA3 or A3 must have high specificity. We don't want false alarms. These must use different antigens or different principles from A1. Strategy 1 is for blood banks. The goal here is maximum sensitivity. We cannot afford to miss a single drop of infected blood. The protocol here is that we run one test A1. If it is negative, the bag is safe. If it is positive, discard the bag. We don't confirm it, we just throw it out. We don't diagnose the bag, we protect the supply. Strategy 2 is for surveillance. This is for counting numbers, not treating patients. The protocol here is we use two tests, A1 and A2. Test A1 is positive, then run test A2. If both are positive, we count it as a case for our statistics. We do not give this result to the patient yet. This is for the Health Ministry's big board. Now for the real work, strategy 3. This is for diagnosis. The protocol is you need 3 distinct tests, A1, A2 and A3. They must use different antigens or principles. If A1 is positive, go to A2. If A2 is positive, go to A3. Only if all 3 are positive, you hand down the verdict, HIV positive. What if A1 is positive but A2 is negative? That is a discordant or indeterminate result. Send the sample to NRL, National Reference Laboratory, for Western blot or PCR for viral load. Do not tell the patient they have HIV yet. Repeat testing may be required after 2 to 4 weeks, which is the window period. We have a special case file, pediatric diagnosis, that is for diagnosis of children less than 18 months. The problem here is the baby has the mother's IgG antibodies. If you use ELISA, it will come back positive even if the baby is not infected. That is a false positive. Solution here is do not look for the antibody, look for the suspect directly. We use DNA PCR on a dried blood spot. Never use ELISA for a newborn. Once we have a verdict, we launch the counterattack. The policy is test and treat. We don't wait for the CD4 count to drop anymore. We start ART immediately. Our goal is the UN AIDS 95-95-95 targets. It states that 95% of HIV positive people should know their status, and 95% of those diagnosed are on ART, and 95% of those on ART have viral suppression. Let's close the file with the cheat sheet. Snapshot this. Screening test is 4th generation ELISA. It detects antigen and antibody. Confirmation is done with a Western blot or PCR. Strategy 1 contains 1 test and it is for blood safety. Strategy 2 contains 2 tests and it is for surveillance. Strategy 3 contains 3 tests and it is for diagnosis. Case closed. You know the enemy, you know the timeline, and you know the protocol. Let's recap the high yield points. Look at the comparison. Innate immunity, it is fast, non-specific and has no memory. Adaptive immunity, it is slow, specific and has memory. Innate buys time, adaptive wins the war. Now the HLA math. Never get this wrong again, the rule of 8. MHC Class 1 found on all nucleated cells, it presents to CD8, 1 multiplied by 8 equals to 8. MHC Class 2 found on APCs, it presents to CD4, 2 by 4 equals 8. If the math adds up to 8, you have the right answer. Open your arsenal, you need these mnemonics. Hypersensitivity is acid. Type 1 anaphylactic, type 2 cytotoxic, type 3 immune complex, type 4 delayed. The Lupus code for SLE is SOAP brain MD. Serositis, oral ulcers, arthritis, photosensitivity, blood, renal, ANA, immunologic, neurologic, malar rash, discoid rash. Well, that was a marathon, but we have built the foundation of immunology. If you have any doubts, drop them in the comments below. Don't forget to like, share and subscribe to Conquer Pathology with Dr. P. Keep studying, stay curious, and I'll see you in the next lecture. I've created a high-yield PDF cheat sheet of all these tables and flowcharts. The link is in the description. Good luck studying.